Appreciate it. And hopefully I can give you some information on COVID and where we're going to be at in the future. Now, I think the most important thing in this kind of presentation is also to talk about where we've been and then where we're going. So the PowerPoint we can I think we can email out afterwards. You can follow along. I kept it very short, and there is a lot of summaries on this to make sure that it's a slide of summation basically, so that we can have very concise information and leave it open for question and answers at the end. So now, coronavirus is just it's a type of a cold virus, and we have 4 common ones, and then we have 3 that are you could say novel or new or man-made: MERS, SARS, and the most recent, as we know, SARS-CoV-2, or as now commonly referred to as COVID-19. Now, if you're watching the news, you know that we are in the 3rd surge since this started. We have about, per yesterday or late yesterday, we have about 68 million people infected worldwide, 1.5 million that have died. And then, we'll focus on for Georgia itself, we have a estimated hospitalization or infection rate, I should say, of about 4,000, and a total U.S. infection rate over 250, over death rate of 250,000. So it's a pretty significant disease process, and it has affected every facet of what we do in our daily lives. And now what we're moving into is the winter. And the concerning part for us in the winter is also, what are we going to do when we have co-infections such as the flu, and how are we going to deal with the virus in the winter, which it seems to be more stabilized in colder weathers when compared to warmer weathers. So I in the slide series, there is a portion right now where we talk about this surge, and we talk about the highest spike we had, which was November 6th with 6,345 cases, and then where we are on a daily today. Now, as part of the Northside network, we have 5 hospitals under our COVID task force, and we are also experiencing the same stress as Emory, Piedmont, Wellstar, and Grady are experiencing now as well. Now, with this, we have to also discuss the incubation period. The incubation period has been reported anywhere from 7 to 14 days, and that means that there is a variable R naught, or what we call in medicine as the ability to spread from one person to the next. Now, here we discussed in 1918, when we looked at the Spanish flu, the R naught at that time was 2. Our R naught for the coronavirus or COVID-19 is anywhere from 2 to 5. And then you've heard those kind of cases of super spreaders from where one person spreads it to 150. So this is a variable R naught, which is concerning to us, because then we can't quantify when it comes to contact tracing. Also, we're seeing this surge, and if you look at that incubation period of 14 days, and Thanksgiving was a couple of weeks ago, the process from an epidemiologic standpoint is people travel, they go somewhere where they might be exposed, they come back, let's say they get exposed on the tail end of their trip, because you're looking at end of November, and now they present with symptoms around day 7 or 10. And during that time frame, let's say they're asymptomatic for the first 6-7 days, and they spread to people around them if they're not practicing social distancing or masking. And then we see that kind of extreme surge later in probably now as what we're seeing, and then late December as well. And this will push likely through January moving forward, as even regardless of the what's happening in the country, mainly because of the possibility of this super spreader phenomenon. Now, one of the major things that you hear is, unfortunately, a lot of our patients from a pulmonary perspective are at high risk. We do have a lot of elderly populations, so the highest risk is still greater than 65, and then those with comorbidities, and now even those that are, of a non-Caucasian race as well, show a higher rate of hospitalization, higher rate of ICU, and a higher rate of mortality. Now, when we look at the hospitalization rate through November 28th, 2020, we went from a pretty high hospitalization rate initially now to around 262.8 per 100,000. Now you say, well, why is the hospitalization rate a little bit better than it was before? It's because more people are exposed. There's more testing, so the number variability works in the statistical favor of these rates that we report. Now the one kind of transition into this, as we talked about the surge that's happening now, that's going to go forward in through late December into January. And then also the next part I wanted to talk about was, flu and COVID co-infections. This is something that is very real. Luckily, we haven't seen that much flu at this time or flu co-infection. And the reason why that's concerning is because the majority of the time, our busiest seasons in the hospital network are during the winter because of the flu. So because of your efforts with masking and social distancing, and then the efforts around the world, we have been lucky to have that less of a flu epidemic than we usually see, and also people's focus on vaccination, early vaccination with the flu, I believe, has also helped decrease these numbers. Because if you add those two, COVID plus flu, those numbers would be astronomical from a hospitalization standpoint. So again, the next transition was, I do hope you get this slide, because this is what we're doing for COVID. And I think that's a big question on everybody's mind, is how we treat COVID-19. And then what therapies are disproven or non-beneficial, and which ones are, FDA approved or approved with a emergency use authorization or an EUA. So the only FDA approved therapy right now is remdesivir. Is an antiviral agent that's given intravenously during hospitalization if the patient requires oxygen supplementation. The other kind of medications that are EUA'd are medications that affect the immune system. They help to decrease that inflammatory cascade, which, like a JAK inhibitor known as baricitinib, and also another outpatient-only approved therapy is bamlanivimab, and the other drug is, as you know from the Regeneron company, casirivimab and the imdevimab combination therapy. Among these medications, the ones that are the antibodies mimic a immune response that allow you to have a immune-regulated defense mechanism that's upregulated against the virus. So these are, however, the ones that do that, like Regeneron, are only approved as an outpatient if you're not on oxygen supplementation. Because the literature shows if you are hospitalized, it might actually be worse for you. So among the therapies that we use in our network, we use remdesivir. We do use steroids, which is, doesn't require FDA approval because it's not a novel therapy. And also we have started to use in our outpatient population either the Regeneron cocktail or the Eli Lilly drug known as bamlanivimab. Otherwise, the most important thing that we have focused on is supportive care, is making sure that these patients who do get COVID-19 get appropriate oxygenation. We do focus on shifting the body to provide kind of a homeostasis while they're in the hospital. We make sure that they're checked on multiple times throughout the day. We have yielded some of the best mortality outcomes in our network when compared to the Southeast. The medications that we've kind of gone away from due to disproven or non-beneficial literature include hydroxychloroquine, ivermectin, which was an antiparasitic drug, azithromycin, and then convalescent plasma. Now, vaccination, I'll end with this and open up for a couple of questions. For vaccinations, we know we have Pfizer, Moderna, and then AstraZeneca. These are the three companies that are, in the kind of the final stages of getting out there. Pfizer's first patient was given the vaccine in the UK, and we're hoping to get FDA approval on December 10th, which is a historic day, as FDA will hopefully approve the vaccination for the US. And then we can hopefully see the light at the end of the proverbial tunnel to make sure that we can get everybody vaccinated as quickly as possible. Now, post-COVID concerns, there are some syndromes that we can get into, but just where we go from here, I wanted to mention what happens after you have COVID if you do, God forbid, get the virus. And sometimes there's evidence of blood clots or POTS, which is postural orthostatic tachycardia syndrome. This is where a When you get from a seated to a standing position, sometimes your heart rate goes too fast and you have to sit down and relax again. This is pre-COVID syndrome, but it is exacerbated if you have the COVID infection in some patients. There is a kind of a post-COVID fatigue and malaise, which is just feeling down all the time. There have been reports of cardiac disease or brain fog from a neurologic standpoint, where you feel like you're, almost in a kind of confused fog-like state. And then there's the taste and smell. We do have patients that we follow that still haven't received their sensations back. Now, are any of these permanent? We don't know, but highly unlikely. So the take-home points, the numbers in Georgia will go up. So please continue to wear, your masks appropriately, maintain social distancing, avoid large gatherings, vaccinate yourself for the flu. When the vaccines become public, will likely be, February, March, and then for healthcare providers, likely, in the next few weeks. And then be mindful of also your mental and physical health. Thank you.
Wonderful. Dr. Chaudhry, thank you so much for all that great information. It's not fun to talk about, but it's all very, very valuable information. So thank you for your time. This session will wrap up, and then we'll invite our guests to jump back over to the sessions button and for the next 15 minutes. So we'll see you over there. Thank you, Dr. Chaudhry. Appreciate it.
Bye.